Hi, I'm Dr. Pedro Castillo in Dallas, Texas with Room Now. We're covering ACR Convergence 2021. Today, I'd like to talk to you about the abstract 1946 for those of you following at home. This was presented by Dr. Silje Waterdal Siversen. This is going over the Norwegian Drug Monitoring Trial, or NORDRUM-B. This is a part of the trial that was looking at therapeutic drug monitoring versus standard therapy for patients receiving Infliximab for a variety of inflammatory diseases. Now, these inflammatory diseases spanned several, including GI and arthritic types of diseases and skin disease. So psoriatic arthritis, rheumatoid arthritis, psoriasis, axial spondyloarthritis, ulcerative colitis, and Crohn's. Now, this was done over 21 different hospitals with 454 patients, divided in half, where half of the group would get the therapeutic drug monitoring, and the other half would be standard of care. Now, therapeutic drug monitoring was basically trying to keep an infliximab level of between 3 to 8 milligrams per liter. The standard therapy was to use basically clinical judgment based on clinical factors of the physicians treating these patients to decide if they wanted to change the dose of infliximab. The idea here is to see if we can try to minimize the amount of patients who are getting an overdosed amount of medication, and also ensure that patients are within the therapeutic range, as well as prevent people from, quote unquote, failing the drug when in fact, perhaps they were just outside of the therapeutic range. The primary endpoint here was for all diseases, all the diagnoses together, to maintain or sustained control of the patients. Now, these, of course, remember, are infliximab treated patients who are on maintenance therapy. Now, in the therapeutic drug arm, they had 74% sustained control, whereas in the standard of care, it was 56%. And this was a significant difference when you're talking about the primary endpoint of meeting all the diagnoses together. When you're looking at the individual subgroups, AS, or axial spondyloarthritis, as well as ulcerative colitis, were significantly different, with the rest of them also being numerically different, in other words, better than the standard of care for the therapeutic drug monitoring arm. But those other ones were not significant in and of themselves. But again, remember, that's a subgroup analysis, whereas the primary endpoint was met for the whole group altogether. This is a really cool study because it basically is potentially practice changing in the future. I mean, if we have a cheap and readily available way to check therapeutic levels of infliximab on these patients, we may find that, hey, they have a too low of a level, and maybe we just need to increase the dose. Or perhaps they have a very low level, and in fact, they have a high antibody to infliximab, in which case we need to switch therapy. Perhaps we find that some of them have a too high of a level, and we can decrease the frequency or decrease the dose. And so that can be important for a lot of reasons. The other thing that they did find in this study that was interesting was that the dose variation was actually lower or better in the therapeutic drug monitoring group. In other words, they didn't vary the doses as much in the therapeutic drug monitoring group. I would have thought that it would have been the other way around, but in fact, those who were just getting standard of care are the ones who changed more often. And the other thing that was interesting was that patients who received standard of care therapy more often had levels that were below the goal. Now, this was an open label study, which of course presents its own various limitations, but it's very encouraging to see that this may be an avenue for better targeted therapy for those patients. Thank you very much for joining me today. This is Room Now. You can learn more at roomnow.com, and you can follow me on Twitter at _Castillo_Pedro. Thank you very much.